As this was an older dog and post-first season, the incision was made just below the umbilicus. The fat is trimmed away. This prevents the subcutaneous fat getting caught in the ovarian clamp and improves visualization of the linea alba. The linea alba is identified and lifted as high as possible for the stab incision. Keep the scalpel handle parallel to the body. This prevents any damage to the spleen. Check your incision site is correct, in that you have entered the abdomen, as it is easy to miss by a few millimeters, and then you would have to cut through the peritoneum to rectify. Extend the incision with scissors, keeping the muscle raised, and the scissors parallel to the body. Slide down the abdominal wall, keeping the abdominal contents behind your finger. Touch the vertebra and then slide back up, using your index finger as a hook. The best place to feel the uterus is just cranial to the bladder. If you need to verify it is the uterus, check for the bifurcation or an ovary. If it's tight, you may have to push down on the abdominal wall to get to the ovary. Once you have the ovary, you can pull harder as it is protected by the ligaments. Place it in your right hand and slide down the suspensory ligament with your left index finger. Break the suspensory by pushing down at the insertion to the rib. Remember there are two ligaments, the suspensory and renal. The renal runs to the kidney. The suspensory runs laterally to the kidney. Do not break the renal ligament. Now make the window in the broad ligament. You need to stay clear of the ovarian vessels. And go low down, so we can place the clamp low. A transparent area is the safest place to make the window. Now place the clamp. I prefer atraumatic calm molts, as they don't damage the pedicle. Walk the clamp down, rather than pushing it down hard. I usually place it about an inch below the ovary. We now separate the uterus, place two clamps above the ovary and cut between. This gives us better visibility and makes placing the Miller's knot easier. Place the Miller's knot under the clamp. Initially keep it loose, so you can lower it. Using atraumatic forceps, nudge the knot down lower, and then rotate the clamp. I use another forcep to maintain the rotation. By doing this, the knot stays low when you tighten. Make sure the knot is as tight as you can get it and follow with 5 to 6 ones. If you have accidentally broken the renal ligament, then the vessels are more likely to get damaged. Keeping the renal ligament is important, as it takes up any tension before the vessels. Keep the tails short. Otherwise they can get caught in the second Miller's. Now we move the clamp closer to the ovary and place the second Miller's. It doesn't matter if you use the crush bed or not. It is vital you can feel some tissue between the clamp and ovary. Otherwise, we will get ovarian remnant syndrome. Here you can see me placing a clamp on the end of the suture material. Tightness acts as a backstop, so I can pull tight without the suture slipping. So I now check for any bleeding. The first clamp is removed, followed by the ovarian clamp. I usually hold the bursa and check there is no bleeding. If in doubt, place another ligature. Now replace the clamp and cut flush to the clamp with the blade. And check again you have cleared the ovary. We have already checked for bleeders, so we can just release the clamp. Some vets don't tie off the broad ligament and just tear it. I prefer to ligate, as I would rather have no oozing. Identify the uterine vessel that stays with the uterus, make a window on the other side. Double or single clamp and tie off with the surgeons if the unclamped part started to bleed. I would then place a clamp on it. I rotate the clamp so that the surgeons can be tied away from the clamp. If you place a ligation very close to a clamp, the clamp prevents the ligature going tight. Feed the other side of the uterus up and trace to the ovary. If the ovary was very tight, I would have to push down to get it. This will be demonstrated in other videos. Hold the ovary in your right hand and trace down the suspensory with your left index finger. Go as far down as you can and push down on the insertion to the rib. The left suspensory is thicker than the right, so sometimes I push it upwards, or break in two pieces, the lower part then the upper. Make your window in the transparent part of the broad, low down, and away from the major vessels. Walk the clamp down while you keep tension on the ovary. Now place your two clamps and separate the uterus. So we repeat as the other side, place the first millers loose. And nudge it further down, away from the clamp and then tighten. I used a pair of forceps on this side to keep the ovarian clamp rotated. The clamp is moved up and then the second mill is placed. After forming the second millers not loosely, nudge it down and tighten. We check there is no bleeding and the clamp is replaced. We then remove the ovary, cutting it flush to the clamp, using the blade. We have already checked for bleeding, so just release the clamp. Make a window in the broad, keeping the uterine vessel with the ovary, and then clamp and ligate. We tie the surgeon's knot, with the clamp rotated, as this stops it being too close to the clamp. We can easily get to the body of the uterus. I use a clamp to keep the uterus exteriorized. I usually place a surgeon's first, as this is less likely to cut through the uterus. With this dog, I follow with 2 millers, rather than a millers and transfixing. I never place crush beds on the uterus. This is because I have had a few dogs where the uterus has broken after clamping, or the vessels have been damaged and had profuse bleeding. I am using 3.5 metric, Neuter, PGA suture. If you go too thin, the suture could cut through the uterus, and it is less likely to snap when compared to 3 metric 20. When cutting, always leave about a centimetre behind the last miller knot. This is referred to as the golden centimetre at some unis. Check for bleeding and then release it from the muscle and check again. I am closing with 3 metric 20 PGA suture. PDS is preferable. However, at the charity, we have to use what we have. I am closing the muscle in a continuous pattern. Then for extra security, I place an Abdominal, about halfway along. When you finish the Abdominal, you are better passing it through twice and not just the once. I now tighten the suture pattern by spreading the loop of the knot. Remember to start the fat layer. In the opposite direction you prefer to do your intradermals. The fat is closed with a continuous pattern. To hide the knot, go deep superficial on one side and superficial deep the other side. You can see here how I switch. So my first pass is deep superficial. This keeps the knot under the fat. Then I go back on myself and continue closing. The knot is hidden by pulling it down. I pass my needle through, cranial to the knot, and then come out at the end in the intradermal. I leave a small hole at the end, which I will use to pass the needle. I finish with a surgeon's knot, as I feel they are stronger than Aberdeen's. It is essential the knot is buried so the wound heals. Wiggle the needle through the small hole, push some skin over the needle. This is so we can leave some of the tail under the skin. Pull on the suture a little and then use forceps to push the skin over the knot. Please support the charity and subscribe.